നെറ്റ് സ്ലോ ആണോ? Hello doctors, I welcome you all to this live section. So here today we are going to discuss a few topics from obstetrics and gynecology, right? So I believe this section will be very useful for you, right? I welcome you all to this live section. And so here we'll today start with our topic, going to discuss a few so the ectopic pregnancy from obstetrics and gynecology. We know ectopic pregnancy is a major complication, so right? I believe, and the section when we see the definition of ectopic pregnancy, right? I welcome you all pregnancy to this live section. And so here we'll start with our topic, right? So the ectopic pregnancy is going to be obstetrics. We know ectopic pregnancy is a major complication, so right? I believe, and the section see the definition of ectopic pregnancy, right? I will see any pregnancy to this live section, and so here we start with our topic, right? So the ectopic pregnancy is going to be gynecology. We know ectopic pregnancy is a major complication, so right? I believe, and the section see the definition of ectopic pregnancy, right? I will see any pregnancy to this live section, and so here we start with our topic, right? So the ectopic pregnancy is going to be gynecology. We know ectopic pregnancy is a major complication, so right? I believe, and the section see the definition of ectopic pregnancy. And in this classification, we understand the most common site of ectopic pregnancy is going to be the fallopian tube. Always it is going to be the fallopian tube, because the fallopian tube is the site where the fertilization itself take place, right? So it is the same place where we can see the ectopic pregnancy occurring also. And for a most when we consider the non-tubal or non-tubal site, most commonly it is going to be the ovaries, right? It is going to be the ovaries. Now the overall least common site would be the cervix, right? The cervical ectopic is the least common site, and followed by you can see cesarean section scar. So now you might think, right, cesarean section scar is in the uterus, right, in the lower uterus, then how can we say it is going to be an implantation outside the uterus only? So this is a slight correction. You have to understand that even in the C-section scar, an ectopic pregnancy can occur. So that definition that we said, that any blastocyst implantation anywhere outside the uterus or endometrial lining is not completely true, because even the cesarean scar, right, is a site for an ectopic, but it is very rare, right, least common. Followed by abdominal ectopic, right? This is a very rarest condition. So in the abdomen also an ectopic pregnancy can be seen, right? So these are the different sites. This is the classification. And regarding the outcome of an ectopic pregnancy, see, ectopic pregnancy, it can have a tubal outcome, right? A tubal outcome can be there, that is a rupture, or there can be an abortion. Suppose in the tube, right, in the tube it is going to rupture. What happens then? So it can be most commonly we say isthmus is the most common site of a rupture of ectopic pregnancy in the tubes, right? So it occurs usually this is going to end by 6 weeks of the period of gestation. And if we consider the tubal abortions, right, that is going to be most commonly seen in the ampulla of the fallopian tube. So that means it is going to be the ectopic pregnancy that ends by 8 weeks. So if it is a rupture, it's going to end by 6 weeks. If it is going to be an abortion, it is going to end by 8 weeks, right? Okay. Now, there is another term that I want to talk to you about, that is the interstitial ectopic pregnancy. What is it? It is also known as what? The cornual pregnancy. So, cornual pregnancy, that is the site would be, in the somewhere here, right? This is the site of interstitial pregnancy. So, you can clearly see this is the site. So, you can see about 2% of ectopic pregnancy is going to be interstitial pregnancy or the cornual pregnancy, right. And at interstitial ectopic pregnancy, it is going to last for a longer duration. Now, when we said it is going to end by 6 weeks and 8 weeks in case of tubal, but here the cornual pregnancy, it can extend further, right. So, that is exactly why we consider interstitial ectopic pregnancy as the dangerous variety, and it contains risk. Now, here I have a table which actually talks about the interstitial pregnancy, ectopic pregnancy, and there is a angular ectopic pregnancy. Now, look into this clearly. Whenever there is an implantation, right, within the proximal tubule, so on the tubule, right, in the proximal tubule segment, that is lying within the muscular uterine wall, right, or you can see that the fallopian tubes for that matter, right. It is always going to be lateral to the round ligament, and it is always extra endometrial, and in USG, right, when we do an ultrasound, it is we understand it's non-viable, and usually it's not much visible also, right. So, that is an important thing to keep in mind. While on other hand, the angular ectopic pregnancy, you can see that the implantation of the embryo is usually, you can see it is superior angle of the uterine cavity itself, right. So, it is superior to the uterine angle, and you can see it is medial to the uterotubal junction. So, that is medial to the round ligament, and it is usually in the endometrial cavity, unlike the other case was in the fallopian tube, right. And also, if we are going to visualize it in the ultrasound, what are we going to see? We can be able to, we can see it's a intraendometrial mass, we can see it, of course, and the viability, right, viability is not certain. Now, one thing to understand is that in this case, the uterus is going to be an empty cavity, right, and you can see the gestational sac, it will separate the lateral edge of the uterine cavity. And if you look into the thickness of the myometrial layer, it is going to be less than 5 mm, right, and it is surrounding the gestational sac. But in an angular ectopic pregnancy, you can clearly see that the gestational sac in lateral angle of the uterine cavity, it is medial to the uterotubal junction, right, and that is why the thickness is going to be more than 5 mm, right, of thickness. Now, regarding the heterotrophic pregnancy, so suppose nowadays there are so much IVF treatments that patients undergo, so there can be a chance, right, that at the same time the pregnancy can occur inside the uterus, right, that is in the womb, and one outside the uterus, that is a ectopic pregnancy, can also be growing. So, the technology of assisted reproductive technologies like IVF can lead to an increased risk or increased recurrence of occurrence of such pregnancies, right. So, in this case, we are not going to give methotrexate injection. Do you know why? So, methotrexate injection we are giving usually for ectopic pregnancy, right. In ectopic pregnancy, we should give methotrexate injection. But this is a case of heterotrophic pregnancy. That means what? There is a growing fetus inside the womb of the female, right. So, we do not want to destroy that, we do not want to harm it, right. Therefore, we are not going to opt methotrexate injection. We will be talking about the treatment subsequently, and you will understand it more clearly. Now we have the risk factors listed here. What are the risk factors to the ectopic pregnancy? You can see if at all a female has a history of PID, right, any kind of a pelvic inflammatory disease, right, it can be a predisposing factor to ectopic pregnancy because even the tubal ligation. So whenever there is an infection, what happens is that the tubes get blocked, right, the tubes are going to get blocked. So when the ovum is fertilized, right, the fertilized zygote, it cannot move into the endometrium, right. By the 4th day or 5th day, it should travel to the endometrium and it should reach the endometrium. But here in this case, because there is a tubal ligation, the zygote formed cannot move inside because of the adhesions in the tubes, right. And that's why tubal ligation is also a complication or a risk factor to this. Then there is cervicitis, endometriosis. Endometriosis is a condition where there is a retrograde flow of the menstrual blood, right. So a bleeding woman, when the blood goes in the retrograde fashion, that can also create adhesions, right, adhesions in the tubes as well. And you can see any case of previous ectopic pregnancy. So if there is a history of previous ectopic pregnancy, then definitely we have to be alert in the in the next pregnancy as well. And any history of infertility. Why? Because she might be on a IVF treatment, right. So that is also to be kept in mind. And smoking, and if at all she is having multiple sex partners. Now there are certain contraceptive methods, right, which is actually basically I can say it's good for the ectopic pregnancy. Why? Because when a female takes progesterone containing contraceptives, right, or POP or progesterone IUDs, IUCD or OCPs, or if in that cases, right, altogether I can say contraceptions are good for it prevents tubal ectopics, but understand, if the contraceptive failure occurs, then that is going to be a risk factor for ectopic pregnancy, right. So that's why the progesterone containing contraceptives, the copper T or tubal ligation, all of this is going to be a contraceptive failures can lead to problems in the ectopic as well. Now regarding the clinical symptoms that we can see in ectopic pregnancy. So you see there is a clinical triad that we can use to identify an ectopic pregnancy in a woman. So whenever a female comes to us with these 3 complaints, that is amenorrhea. So amenorrhea is seen in a woman who is having who is pregnant, right. So that would be a sign in amenorrhea also. So amenorrhea is there, but more specifically you can see abdominal pain and vaginal bleeding, right. So if bleeding, abdominal pain and amenorrhea is seen in a female, you have 2 differential diagnoses. Either it can be a case of abortion or it can be a case of ectopic pregnancy. Now we will discuss further and you will understand how we can differentiate it, right. So we have to consider if the woman have conceived with IVF. So I have mentioned it earlier. If she is having amenorrhea for more than 4 weeks, more than 4 weeks, then we have to consider that patient also as a ectopic case. And a patient with hemodynamic instability and acute abdominal pain. So many a times when such a woman comes to the ED, right, or a surgeon, right, they can misdiagnose this case as a acute appendicitis because she is coming with the abdominal pain, right. So in every reproductive age females, it is always first we ask what? We ask the LMB of the patient, right. So we have to clarify that she is not pregnant, right. So these are the things to consider. And Coming to the symptoms, right? So symptoms of such a patient, I already told about the pain, right? So pain and discomfort will be the additional symptoms seen. So in the lower back, abdomen or pelvis, there is severe pain seen, right? And you can see it is usually unilateral pain, right? And you can see sometimes this pain, right, it can be radiating, or whenever the fluid level, intraperitoneal fluid is going to rise, right, if it is an abdominal pregnancy, right, it is going to lift the diaphragm up, right, and it can cause a shoulder pain. So you can see it is because of the free blood tracking up, and it can irritate the diaphragm and cause shoulder pain in a patient, right. And additionally, pain while urinating, and there is pain while bowel movement. This is particularly with abdominal ectopic. And regarding the bleeding, so vaginal bleeding, usually it's mild, and you can see sometimes these patients have an internal bleeding also. Internal bleeding is known as the hematoperitoneum. So in a hematoperitoneum, because a hemorrhage, right, hemorrhage from the affected tubes, a tubal rupture, right, leads to the internal bleeding as well. So if at all she is becoming unstable, right, before she becomes unstable because of the hemorrhage component, she'll be dizzy, right, or she'll be so tired, and she'll feel headache, weakness, right, all because of bleeding. Now regarding the ectopic, we have to consider a ruptured ectopic and unruptured ectopic, right. In a ruptured ectopic, please understand, the abrupt onset of severe pain is seen, right, when the rupture occurs. Of course, there is an abrupt onset of the severe pain, and the patient will complain of a pain in the upper and middle abdomen, right. So in a ruptured ectopic, especially due to hemoperitoneum, right, or abdominal ectopic pregnancy, you may see the pain is going to be in the upper or the middle abdomen, right. And next thing to notice that the symptoms that you see. So earlier I said about the shoulder pain, right. What is the sign known as? Anybody? So the sign that is shoulder pain, shoulder tip pain, that is known as the Danforth sign, right, Danforth sign. And also you may see the pooling of blood in the pouch of Douglas, okay, which is also known as cul-de-sac. So there is a urge to defecate also. And additionally, the patient, like I said, because there is a ruptured case of ectopic, there will be bleeding. Because of bleeding, she will have syncopal attacks, right. Hypotension would be there, the BP will be falling as well. So these are the symptoms, and you can see on general examination, such a woman, you can see there will be hypotension along with tachycardia, right. These are the things to note in general. But per abdominally, what are we going to see? Per abdominally, you would see a rebound tenderness and abdominal distension, right. So these are the guarding signs, so the rigidity is seen. So guarding or rigidity sign is seen means what? Then that is a localizing sign for peritoneum, right. It's a localizing sign. And regarding the per vaginal examination, on per vaginal examination, what are we going to see? You will see that the uterus is going to be enlarged, right, and there is cervical motion tenderness, right, and you can see also the adnexal mass, right, presence of adnexal mass and salpingitis. Because of that, there is a rebound tenderness. And a case of ruptured ectopic, always it is going to be surgical management, right. But when I talk about unruptured case, unruptured ectopic, that means that is what? Then we can medically manage it. But a ruptured case where a patient is hemodynamically unstable, she should be considered for a surgical management only. That means laparotomy along with salpingectomy, right. So that is the management in this patient. Now I have a list over here. We will consider 3 different cases. You see, a stable patient coming to us with pain and amenorrhea, right, more than 4 weeks, and bleeding, right. What are we going to do in such a female when she comes to us with amenorrhea and bleeding and pain, because that is a triad we considered in ectopic pregnancy, right. So, such a female always we rule out, we have to make sure she is pregnant, right. So, we do a urine pregnancy test and it comes out to be positive, because ectopic or the uterine pregnancy both has both comes out to be positive, right. So, UPT is positive. What is the next step, or what is the treatment of choice? TOC means treatment of choice, and the treatment of choice in this case would be transvaginal sonography, all right. So, what are we going to do here? You can see gestational sac along with yolk sac is seen in the tubes, okay. So, that might be a result, okay. The next case would be in a tubal case, we can see gestational sac and yolk sac in the uterus. That means it is a uterine pregnancy, right. And a third case is that there is an empty uterus, the empty uterus along with a right adnexal mass, and when you see a Doppler ring of fire appearance, right, that is a case of, then in that case if we see such a sign, then we have to do a beta HCG level. Now, in the case of beta HCG level, right, we have to do a series of beta HCG. Beta HCG, you can see it is the critical titer that we consider, right, critical titer, that is going to be 2000 international unit. Whenever the this range, the critical titer, that is 2000, is going to be more, that means more than 2000 international unit, that is a case of ectopic uterus, right, ectopic uterus. But if the HCG is less than 2000, okay, then we have to always repeat the HCG in 48 hours. This is the strategy. So, level of HCG after 48 hours. Is it doubling? Is it the same? Is it reducing? This is what we have to understand. If the beta HCG levels doubles, that is intrauterine pregnancy, right? We all know this. Intrauterine pregnancy only shows a doubling of HCG. And in case of whenever there is an increase but there is no doubling, you can see an increase but it is not doubling its amount, that is a case of ectopic pregnancy. And finally, if the HCG levels are decreasing, that means it is a case of abortion, right. So, only after doing ultrasound, right, transvaginal ultrasound and a critical titer or a series of beta HCG study is done, we will be sure that it is a case of ectopic pregnancy, or if it is a case of intrauterine pregnancy or an abortion. So, this is important. Now, regarding the management of unruptured ectopic, I said it is going to be medical management, right. So, medically what are we going to do? If the vitals of the patient is stable, if it is a unruptured case, we are making sure, right. And if the beta HCG level is less than 5000 international unit, if the size of gestation sac is less than 4 centimeter, right, or the family is not complete, okay, we consider these things before we consider the surgical or medical management, right. And you can see preferably the cardiac activity should be absent, all right. And the drug of choice is methotrexate. We should be giving her a single dose of methotrexate. We are giving it in the IM dose and 1 milligram per kg, right. So, that is a case of ectopic pregnancy. Finally, on this slide we can see we told and discussed about different ectopics, right. So, you can see the cervical ectopic, right. So, just understand the names, okay, that would be enough. In a cervical ectopic, the criteria that we are using is the Rubens or the Palman criteria. In an ovarian ectopic, what are we using? The Spiegelberg criteria. And in the abdominal ectopic pregnancy, we are using a study form criteria. So, these are the different criteria that we can be using. Alright. So, that is about the ectopic pregnancy. I think we can do a couple of questions so that we can understand the topic really better, right. So, I will just take the questions here. All right. So, we can do this question here. So, you will understand from what we have studied, right. Here we have a female who is 27-year-old and she is presenting to us with complaints of mild lower abdominal pain. There is vaginal spotting. She has a history of 6 weeks of amenorrhea, right. In the beginning lines itself, we have got the symptoms, right, that we were discussing in the topic. Now, when we examined her, she is hemodynamically stable, and when we did a TVS, it revealed adnexal mass, right, adnexal mass, which is 3 centimeter, consistent with an unruptured ectopic pregnancy. And there is no fetal cardiac activity that is found. And when you do the beta HCG levels, we can see it comes out to be 2000 international unit per liter. What is the most appropriate management for this patient? Now, you see we have 4 options here. According to the question, we have got a woman who is having bleeding, right, pain is there and amenorrhea, and there is no cardiac activity. On TVS, we also see there is adnexal mass. Considering the options here, option A, expectant management, option B is methotrexate therapy, option C is linear salpingostomy, and option D is resection, right, resection anastomosis. So, what do you think is the answer to the question? Because the beta HCG level, you can see it is coming out to be 2000 international unit, right, and she is hemodynamically stable. What are we going to consider? We are going to consider methotrexate therapy, right. The surgical management is not required because she is hemodynamically stable. It is a unruptured case, right. That is exactly why medical therapy is the option. But considering other options here, you can see these are going to be the medical management, but I mean the surgical management, but expectant management. Are we going to wait and then symptomatically or expectantly going to treat her? No, because the beta HCG level is 2000 international unit, right. So, that is why all of these clinical triad was found in the question that we discussed. And regarding the presence of adnexal mass on PV examination, and you can see guardic and rigidity, right, that is the localizing signs for the peritoneum. We can consider another question here, right. So, we can see a 30-year-old woman who is presenting to us with a lower abdominal pain and smarting, right. So, you can see there is a history of 8 weeks of amenorrhea, right, and we can say this patient is also hemodynamically stable. Her beta HCG levels, you can see it is measured to be 2500 international unit per liter. After 48 hours, right, after 48 hours, we are going to check her beta HCG level again. So, it comes out to be 2000 international unit per liter. And you can see subsequently when we record it, it reduced to 1000. So, from 2500 to 2000 and from there to 1000 international unit per liter. Now, the TVS is not showing any evidence of gestational sac in the uterus and the adnexa. And the question is, what is the most likely diagnosis? Now, we have 4 options here which might be the answer to the question. You can see option A is saying intrauterine pregnancy. Option B is unruptured ectopic pregnancy. Option C is non-viable intrauterine pregnancy, and option D says molar pregnancy. So, what do you think is the answer to the question? Obviously, she is having the clinical triad that we were talking about. She is a stable patient and there is no gestational sac as well. Here it is a clear case of non-viable intrauterine pregnancy, right. So, it is a non-viable intrauterine pregnancy. It is clear that the levels of the HCG also decreased, right, and there is no gestational sac in the first place. So, we do not want to be confused with other cases. Intrauterine pregnancy HCG levels should double, right, and unruptured case also there will be changes that we have to see. There will be increase but not doubling. And then molar pregnancy, definitely you will see HCG levels are grossly elevated in a molar pregnancy. So, here it is a decline seen. So, that is the basic, you do not need to understand or get confused. Just the HCG levels would help us to track down the answer here. So, that is why again repeating, management of ruptured ectopic is laparotomy and salpingectomy, and in case of unruptured case we have to give the methotrexate 1 gram per day, right, I mean 1 milligram per kg, that is a single dose given, IM route, right. Okay. Right. So, I believe this section was clear to you, and I hope it was informative as well. Thank you all.